I think, you know, overall, nationwide, our response to the pandemic has been pretty dire. And the one thing that's really shone out as far as Britain's contribution to this has been the research that's gone on, and the fact that we've made such a big contribution to that at local level, I think is something that we can all be really proud of. One question for you though, are there any lessons about the way in which research is conducted at Chesterfield that you think are transferable to a future post-COVID environment? And do you have any thoughts about that?
I'm sorry, you broke down at some point. Could you repeat the questions for us?
Okay. The question is, are there any lessons about the way in which research is conducted in Chesterfield that you think can be transferred and taken into the post-COVID environment?
So I think that was fundamental here is that we are a small team of very motivated individuals. And in an organization, you don't employ skills, you employ attitude. And what is very important in our team is that we're already motivated. And Amanda, as a leader, she's able to inspire us. So she doesn't motivate us, she inspires us. We've already got all, the skills are all there, and she just tells us every the way. And instead of just saying, she shares a purpose. And that's, I think, is brilliant. Because if you have a purpose, then everything comes into play. And what we've been able to share is that the eligibility checklist, which may seem is quite an extensive document that we wrote. We shared that, and there was an article that another colleague who came from the research task force was able to share with the wider community. Consenting to drug studies is not easy because, of course, we're nurses, we're not medics. But we've got extensive skills, and we've got more time to dedicate to our patients. If every other bigger hospital could just focus on their research nurses a little bit more in every single study, it's not just the COVID one, I think they'll be able to recruit more, but at the same time give importance to that patient, because without that patient, we wouldn't have the results that we have. So we need to be thankful to every staff member on the ward, which they welcomed us in a very nice way, and at the same time to all the patients who decided to participate, because it shows courage. It's not easy to accept to do a drug studies that for a disease you don't even know anything about. I hope that answers your question.
Yeah, thank you.
I don't know, Amanda and Victoria, if you're following the chat in the chat box or whether or not you can access it, but it's if you have hot ears, you'll know why. There's loads of lovely comments about what a fabulous job you're doing, and reflecting on your language of empowering, inspiring, and professional, and much applause for all you have achieved. So we're very grateful, and we're very impressed that you've put Chesterfield on the map in this way, and prioritised the current and future health of our patients, perhaps at a level that they wouldn't normally expect in a DGH. So it's particularly impressive. And the other comment in the chat is about, we wish you all the best in your nomination for the Chief Nurse Award. And we very much hope that you'll be coming home with the relevant trophy when all of that's decided. So well done on the nomination, and thank you for joining us this morning. So we'll just pause as Amanda and Victoria sort out screens, and we will look to our next item, which is under the next section, which is about culture. And we have the report of the Chief Executive. So if I can start to you, please, Angie.
Thanks, Helen, and what a start to our meeting. I'm not sure I can follow that. And I promise it wasn't planned, but Amanda and Victoria have done a perfect introduction to the context I was going to set from my report, which was about the importance of looking after our people, because they will look after our patients. And obviously, since I wrote the report and since our last meeting, COVID has increased in terms of its presence and impact on our organisation. not, I have to say, to the degree that it has across other parts of the country. But at the moment we have 6 patients COVID positive in our inpatient beds, one of whom is in ITU. And sadly, we had to report another patient death last week, which brings the total patients we've lost to COVID to 140. To set that in context, we've had 593 patients admitted COVID positive and 587 discharges. So an ever-changing picture. And for our board discussion today, I wanted to focus and particularly draw out the people plan agenda that Jeremy and Zoe will take us through later, and the RES annual report in terms of that really important context of heading into some challenging times for all of us, I'm sure, and how we keep the motivation and inspiration that we've just heard from 2 members of our staff across the whole of our organisation. I also particularly just wanted to highlight, you'll see them there, but there's more examples of some fabulous work that our teams are doing, the good rating from the CQC for the Grange, the work in care homes that our MDT teams are doing, and other examples that you'll see. And listening to our staff and our patients continues to be really important. We've continued to hold listening events that we're learning how we can do things better. I have to say I was pleasantly surprised, having braced myself for one of those events, just to have someone say thank you for what a great organisation and the support that they felt when they were COVID positive and had to take time off. But there are things that we can learn from. And again, keeping an eye on our workforce and absence at the moment is key. And I'll ask Zoe just at the end of my report just to give a quick update on our workforce position as of today. The challenge of restoring services in that context is ever progressing, and you'll see Tony has on the agenda our latest update in the plans that we've got in place to restore our services. And I also just wanted to acknowledge and mention the fabulous work that all our teams are doing behind the scenes to submit data returns. I was going to say you wouldn't believe, but you may believe the number of returns that we have to submit. It feels like by the hour at the moment, to make sure that we are reporting on absolutely everything from our workforce to every individual service. And we're making progress, not as much as we'd like perhaps, but some really hard work going into both reporting and making those services safe and in place for all our patients. In that context, you'll see the update on Joined Up Care Derbyshire and the progress that we're making towards an integrated care system. And again, all the work that we're doing jointly as part of a system, which is really starting to take shape and pace. And the last area I just wanted to draw attention to, you'll see that the flu plan is a consent item on the agenda, but as a board, we are committing to supporting our teams to ensure that all our staff have access to the flu jab. So we've taken it as read, and I know all of you have been busily organising getting your jabs, and Helen and I are looking forward to ours later this afternoon in front of the camera, but thank you to everyone for all their efforts in making sure that we keep our staff and our patients through our primary care practices as safe as we can. And when Zoe's given the workforce data, then I'll just ask Sarah to give us hot off the press our flu staff vaccination data, because we made a flying start. So I just want to acknowledge that and say thank you. So Zoe, if I could just ask you first and then Sarah to follow, and then happy to take any questions.
Thanks, Angie. So in terms of our current position on sickness absence, this is one of the many daily data returns that Andrew referred to. So we've obviously continued to do this during the course of the pandemic. The latest position is overall sickness absence standing at 5.2%, of which 1.47% is COVID related, either sickness or impact of self-isolating due to household members. To give some sort of context around that, during the month of August, we saw sickness overall had been declining in recent months, and during August it was usually at or around 4% overall. During September, it's been usually on most days above 4 and into the 5s as well. Not quite reaching 6 on a day as yet, and we see this has been linked to return of schools largely, and the impact of school bubbles being affected, and then the consequent in terms of symptomatic and also asymptomatic sort of children, and therefore impact on family members also in terms of self-isolation. Also earlier in September there were delays in accessing tests. As an organisation, as a system, we've taken steps in more recent weeks to support our own people to be able to have access to tests. But when there were delays with the national system, that was obviously impacting in terms of people being able to access a test to be able to return to work. So that is our current position. I'll hand over to Sarah.
So current flu vaccination position, we are day 7 of our vaccination programme today, bearing in mind we started a week earlier, so we're 5 days ahead. So current position on day 7 is 26% of our frontline, all total staff have been vaccinated. That's 1,182, which is just phenomenal because we had to cancel the session, so that is absolutely phenomenal. To put that in context with last year, as I say, we're 5 days ahead, and at this point last year we were at 23%, so we have absolutely made a flying start, so well done everybody.
You're on mute, Helen.
Thank you very much. I was just saying that's very impressive. So, colleagues, any questions you'd like to come in with on the back of anything you've heard from Angie or colleagues there?
Atul's just asking about feedback from BAME colleagues in the networking event, so Zoe's putting a hand up, and I know there was a discussion yesterday afternoon, so do you want to feed back, Zoe? Thank you.
Yeah, I can talk to that. So the group met for the second time yesterday, sort of late on yesterday, and I went along to the to be part of that and hear the conversation. I say the group because one of the items for conversation was what to call the group, and there are different views around whether to use the word BAME, for example, or not, or whether to call something else. So it's very much sort of forming and coming together in terms of purpose. Some of the practicalities around how best to engage with people, how we can communicate, how we can promote, how we can involve people, so people know it's available, and also how we can make sure that people know that they can have time in work to come along to the group. We've said that quite clearly. It was clear to me yesterday not everybody's heard that, so in terms of cascading some messages, we've got a bit more work to do around that. Some of the conversation yesterday was also around, how the group can share their experiences and escalate as they wish to. And there was a lot around sharing positives as well as negative experiences. People were saying we want to do both. We want to do things around education. So there are lots of ideas around how there could be celebrations. So, for example, at certain times of year, they could. So, I'll give an example. Next year, it's the 20th anniversary when the first cohorts of international nurses from India came along, and one of whom was talking yesterday and saying, "Oh, maybe we could do something around that next year as a bit of a celebration." So, I felt there was a lot of energy in the conversation, a lot of focus around how the group and how we as a trust can start to make improvements. And like I say, it was very much around, let's share positive experience as well as negative experience, because they want it to be a positive place and a sort of a positive group, and they want it to keep growing. So early days, I think it's fair to say, Atul, there was a commitment to continue with monthly get-togethers. So one of the other conversations was, is it a meeting or does that make it sound too formal? So some real kind of practical points, but I think that are quite important when a group's coming together, because that's language is how you attract people.
Thank you for that. We've a question in from Beverly too about if we're doing enough to test our own people. Who'd like to take that?
Tony, I'm assuming you'd love to take that one?
I'd love to take that one, thank you. So yes, we have a programme where we do test our staff if they are symptomatic. That is still the stance of the NHS. We are supporting what's known as Pillar 2, where the public and members of our staff can go to those facilities if they have symptoms and get swabbed accordingly, and we're supporting the testing there. And we've set up very much locally for our key people, if they're identifying to us that they have at least tried to get onto the government website and not been lucky enough to get on there, then we can make provision for them to be tested. But we would be overwhelmed if we took it all on. So we have to they have to demonstrate to us that they've tried to get on the government website and access that service.
And I'd just add to that, some of our own staff being tested through the Siren research. So just to link back into Amanda and Victoria's presentation, and I heard yesterday on the regional meeting how a member of staff in an outbreak had been picked up through Siren testing. So we'd just encourage any members of staff who still haven't volunteered, I think there's still a few places, then that is an avenue that staff can get frequent testing.
Very good. Well, thank you very much for that report. Very comprehensive as ever, food for thought. And I'm going to move us on, if I may, to item 5, which is about the board assurance framework. So we've got board assurance framework for information. We've got an indication of how it is. Angie, having worked with some board colleagues, would like to evolve the board assurance framework. Of course, this is also the opportunity for us to hear from committee chairs, and in particular on this occasion, Jane, as the Quality Assurance Committee has met since the last board meeting. So we might start with you, Jane, if we may, please.
Okay, thank you, Helen. For this month, we actually don't want to make any recommendations around any changes to the ratings on the board assurance framework, but there are a few items that from the committee that I would just like to bring to your attention. The first would be that we have followed through on an ask that was given to the committee, which was to review the requirement or not for an ethics committee as a standalone committee within the trust. And the Quality Assurance Committee received a recommendation that a standalone committee wasn't required. And as part of that discussion, we also had quite a lot of information about quite a lot of discussion and thoughts about how our assurance processes are working. And we heard that there is a review underway of how the assurance processes actually connect together, and there'll be further recommendations from that. So that's really welcomed. As chair of the committee, I'm really keen to understand that our escalations in terms of things that come to the attention of the Quality Assurance Committee are there and working really well. And just to carry on that theme, we also have been reviewing the quality report, because it is a really, really fantastic report, but it is getting really, really heavy, and sometimes it's quite difficult to find the wood for the trees. So we've got a review of that underway, and actually we're looking forward to looking at that further with Krishna when she starts. So I think those two things in terms of the governance of the committee and the governance committee, the governance assurance processes per se, are really, really good things that we're doing. And the second thing that I wanted to bring to your attention was the fact that we also have asked for a deep dive on falls. Now, this is actually more of a positive than a deep dive where we have concerns. It actually comes on the back of us making significant progress and us funding the falls prevention lead on a permanent basis following the success of the Sequin programme. So what we want to do is we just want to make sure that that work remains visible, and also to understand the progress that's being made. So we're expecting that deep dive to come to I think the next committee. In terms of receiving annual reports, we received tissue viability annual report, and I bring that to your attention because actually it was a really good report, because actually what it does is it shows the real breadth of work that the tissue viability team undertake, and that's far, far, far beyond the work that we do on pressure ulcers. But it also raised an issue about capacity, and again we expect to see a service review and a business case going through the hospital leadership team on that. I want to also just focus on clinical effectiveness. We continue to do work on clinical effectiveness, thinking about that third pillar of quality and thinking about how we bring together everything that we do in terms of all of the different programmes. So, for example, National Audit, GIRFT, and also, thinking about things where we get adverse reports, so through mortality outlier reports, etc. So that pillar of work we continue to focus on, and that remains our focus through QAC for probably this year, our main focus. In terms of a final topic, I wanted to just talk about infection prevention control. This is really critical, and particularly at the current time with COVID. And actually, we've had to complete a self-assessment on the National Assurance Framework. And what I really wanted to just emphasise is that our evidence has been tested. We've had conversations with our CQC inspector. We've looked at our rating. We've looked at our evidence with the CQC inspector, and actually our evidence has been found to be really robust. And we have had a really positive report back from the CQC inspector on that. So that is really good. And saying that, what I wanted to do at this point was to just bring in Sarah to make some further comments on infection prevention control, because I think it's really important that the board really understand the importance of this and the great work that's happening currently.
Thanks, Jane. And it links to obviously the IPC annual report, which is further on the agenda. Massive amount of work completed, as you'd imagine, during a pandemic. Our annual report may reflect on the year gone, but actually possibly doesn't then reflect on the work that's happened as part of the pandemic in as much detail. They've been pivotal, and our current position in terms of infection prevention is that we have not had a nosocomial outbreak of COVID-19 in the hospital in Q1, which is a really strong position. Obviously, that is a continued watching brief. We are very clear, and the moment that we have a suspicion of that is investigated thoroughly. Indeed, we've been through that process this week, so we are monitoring that really closely. But that, I think, is really testament to our staff, but we absolutely need to maintain that message, and we need to ensure that we are doing the right things. So I reinforce the daily drumbeat of space, hands, mask, and we can't emphasise that enough.
Thank you, Sarah. Thank you, Helen.
Thank you, Jane, and thank you, Sarah. Now, we haven't had meetings of the other committees, but I'd like to give committee chairs an opportunity to say anything they might wish to add or contribute on the back of the IPR or otherwise. And then, Angie, just to put you on notice that I'm going to come to you to perhaps point the way for the future approach to BAF. Any other committee chairs? Not that I can see.
Yeah, Helena, it's Mike here. We haven't had a full audit committee since last board, as you quite rightly say, but yesterday we had an audit wrap-up meeting with KPMG. It was only a 40-minute session, but just to confirm to the board, as most of the members of the audit committee are already aware, it was a very smooth audit. We learned quite a lot of lessons from the COVID-enforced distanced audit, which KPMG managed to do without bombarding us with staff on site. Clearly, it looks like this current year's audit is going to be the same again in terms of a lot of distance auditing. But it was interesting to hear their partners say, as we've been saying in the hospital, that even with COVID disappearing, that the new norm will be quite a lot of distance working because it's worked so successfully. So I just wanted to pass on. I know we've done it a number of times, but thanks to our finance team, very clean audit, very good thumbs up from KPMG, not only in terms of the quality of the financial analysis, but also of the way the two teams managed to work in the difficult environment.
That's very important to hear. Thank you, Mike. Jeremy, anything you want to add?
Only that obviously the big thing that's happened as far as people are concerned is the NHS People Plan, and we're coming on to that later in the agenda. We have a People Committee early next month, and we'll be picking up some of the things we're talking about today at that, and obviously reporting back in due course to the board.
Very good, thank you. And we haven't got Alison with us, but if any member of the Finance Performance Committee would like to add anything, very welcome, but mindful, of course, we'll have other opportunities to cover some of that terrain later in the meeting. Okay, in which case, let's go to you, please, Angie. Future of the BAF.
Thanks, Helen, and thank you to colleagues who met and discussed our future BAF. The areas I want to draw out for discussion and the ask of the board this morning is we acknowledge that there's a lot of good about our current BAF, and I think it was Mike that says hasn't found any perfect BAF in any organisation, so if anyone has, please let us know. But acknowledgement of all the work that we've gone into it. We discussed how we tend to get very operational and had an interesting debate about whether we should have had a pandemic as a risk, a strategic risk on our BAF, which hindsight being the wonderful thing, was an interesting conversation. But I think it was just illustrative of how do we keep that strategic focus as a board while driving and informing up the discussion from all of our teams in the front line. And where we got to was, helpfully, NHS providers had just produced the slide pack, and I felt it worthwhile including all of it in the paper, because I think it really did sum up well the conversation that we had. And the areas we wanted to pull out was that trying to see the trends, using the deep dives that Jane's already referred to focus us more strategically on our discussions at board, and we acknowledge that it's the amount of information we put into the presentation at board in the BAF that informs that discussion. So we thought the slides that we've referred to in terms of seeing that trend and that forward look would be helpful and build on the work that we've already done. So it's to ask board for support or any other areas that they felt needed adding, and to again ask for your support and acknowledgement that this afternoon we'll be doing our risk appetite session, so perfect timing in terms of having some opportunity to take a step back and think how we as a board approach risk, and also obviously we're refreshing our strategy. So in terms of rewriting our strategic risk, then perfect opportunity again when this comes back in November. We'll be having some revised draft objectives, having done all that work. So they were the asks from board today, please.
Thank you, Angie. Can I invite colleagues to contribute at that point?
Yeah, sorry, I got my hand up, but I'll just jump in. Yeah, it was a good session on the BAF, and Angie's right. I mean, I've never come across a perfect BAF, and 20 years ago, risk registers and board assurance frameworks were barely mentioned, and were we in a safer place? Probably yes, in many instances. That said, we've got to keep our focus on providing accurate and timely information to the board about the risks that we face. And I think we've probably got the balance right between writing down words on bits of paper about what we're going to do, but far more importantly, actually doing it out in the hospital. And I guess that's the balance we need to try and achieve, is not to sort of rely on, a 20, 30, 40, 50 page tome of words, but are these behaviours being embedded throughout the hospital? And that's far harder to demonstrate. And you could argue that we didn't have the pandemic on, and here we are in a terrible situation. But had we got the pandemic on the risk register, it wouldn't have really made that much difference to our response to it. So I'm struggling a little bit to get that balance right between words and bits of paper, which is semi-important, and what we actually do, which is critically important. And I think as long as we can make sure that the information we get is moving towards that, this is what we're doing. And if you get a chance to look at those NHS slides, that shift to the right sort of comment that's in those documents is testament to try and say, look, this is how we've improved, this is what we're doing. But it still all has to be about what our great people do on the front line, and not what our administrators, and I include me in that, write in a board assurance framework. But I think it's a step in the right direction.
Thank you, Mike. Sue.
Thanks, Helen. Yeah, I'll just echo everything Mike said. And it's great that the task and finish group have done the work. It's all really sensible. And I think one of the tricks always will be how will we know whether this makes any difference? So I think that's the point Mike's kind of saying, isn't it? That how do we now take that thinking? You know, like one of the weaknesses was the risks are too broad and operational. Well, but how do we fix that? And then exactly how do we track whether, like, what are our measures of success going to be for this revised approach? And I think that's something we just need as a board to turn our attention to, so that we don't turn it into another academic exercise, because risks, and with Mike, I've worked in lots of organisations and I've never seen it done brilliantly. But I think we could be certainly more pointy about how we track our success. So I'm happily contribute to that conversation at board. But thank you. It's good to see it progressing.
Lee?
I think it was a really helpful session, Helen, and I think the risk appetite session will help this afternoon. I think all organisations face this conundrum between the management of strategic risks and what are the absolute objectives for the organisation and the system, and how is that changing, versus more embedded risk management processes within the organisation. I think we're doing a lot better about the embedded risk management process within the organisation. It's just getting that reconciliation working a little bit more smoothly, that we've already done quite a lot of work at, and really having a distillate out of the bath to say to the board, these are the things that are changing, therefore this is how we need to change and govern our response. And I think the session this afternoon will help with that.
Yes, yeah, I'm sure you're right. But as colleagues have said, great progress, and really important that we get this as right as we can. Angie, just to conflate now, if I may, items 5 and 6. So we've kind of talked about the BAF, how it's working. We've had updates from committee chairs. In conclusion, I suppose the question I would ask you is, reflecting on the IPR in totality, are there any items not covered elsewhere on the agenda that you think we need to pause and reflect on now, or any asks for support, assistance or advice from executive colleagues in respect of the IPR that we should consider in the risk items?
I don't think there is, because I'm looking at the screen, Tony. I'm looking at you for a second, because I know from the workforce point of view, people plan, Zoe will pick up all areas there. I think Sarah and Jane have picked up from the quality, and we'll come on to that in item 7 further. Tony, it was just to check that from the phase 3, it's not explicit, but by inference, are there any areas in terms of performance that you wanted to flag as we run the show day to day?
The explicit ones I would mention, because as a board we're well used to having a couple of the parameters that makes us react. So as an example, 52-week breaches is usually a no-no in this organisation, and because of the nature of the clinical prioritisation of our patients, i.e. the sickest and most needy first, then all of our 52-week breaches are reviewed clinically, but they are of a clinical rating that they're not a priority at this stage, and we don't have the capacity to completely eliminate those breaches. We can hold it, we can reduce it a bit, but we won't get it back to zero during this COVID period. And I guess if that's one point I would make for board, I would draw that out, because it does stick out like a sore thumb. With the cancer ones in reverse, though, because we are focused on looking after them, the clinically appropriate, then you will see the 104-day breaches and 62-day compliance, etc., slowly creep up. Improve, I'll say, because the opposite's there. Say will improve. They're the 2 points I would draw out.
I think on those points, and more generally, and I'm sure I speak on behalf of the board, and perhaps all of this goes without saying, but it's going to be very important that despite our desire to be compliant with targets, that our decision making is driven entirely on the basis of clinical need. Because they're the decisions that our patients and our wider community are relying on us to make.
Yeah, and I think that I completely agree, Helen, and very reassured by the system conversations as well, that that's how it's been led. We are getting a bit of pushback from region around our recovery, but that's the message we keep coming back, and very confident that that clinical prioritisation is there. It's not where any of us want to be, clearly, for those patients that are having to wait a bit longer. But thank you for that, because it is really important. I think we keep reiterating that message.
Very good. Thank you. I'm going to move us on now to the next section of the agenda, learning, improvement, innovation. And the first item under that is item 7, our quality report. Sarah.
Thanks, Helen. As Jane has already described, there's work underway through the Quality Assurance Committee and the subcommittees of that to develop this further. So this is the quality report for Q1 in its current style and format, albeit focusing on the 3 pillars of quality as Jane's described. So the elements that I just wanted to pull out were the challenge of maintaining the assurance to board and to hear effectively from our patients and through our assurance mechanisms through the situation as we are fully cited on in terms of COVID. So from a patient, something's popped up. From a patient experience perspective, how we hear from our patients during this time when nationally we've suspended paper, etc., and how we develop. So where we're at currently from a patient experience perspective is hearing through SMS, and we are developing that. And our first quarter gave, I guess, the key point from in terms of an improvement. Sorry, I keep getting distracted. The little pop-ups just popping into my eye line. I do apologise. From an ED perspective, I just wanted to highlight the increase in FFT scores. So in the midst of the early challenges through COVID, our friends and family scores in ED improved. Whether we will see that continuation, and our suggestion is that we will see that will tail off. I think the early positivity around the NHS, people are tired, our staff are tired, and our public are tired, so we may see that's tailing off. The other element I wanted to just pull out is the amount of audit activity that continued through COVID as well, despite the requirement not to upload. Much of that work actually continued, so that's a real positive for our staff. And we have some really good information to support our improvement trajectory on there. Our reporting culture has improved. You'll see the trajectory there. And I think what the overarching message for me is around the momentum that's been maintained throughout this period. What the ask of board really is what is the future to support our QAC development? How do we take this report forward in a way that helps board gain that assurance, and whether there are any items that we feel our public are telling us differently that we maybe want to explore. So I guess that's over to colleagues to ask in terms of that ongoing assurance in a time where we have limited visitors, we have limited footfall. How do we maintain that assurance for our public?
Okay. Angie, did you want to come in?
Yeah, I think we acknowledge that the quality report is going through a bit of a process at the moment. So that's Sarah's ask there in terms of, and I can see Keith and Sue have got their hands up. So it's a balance today between the key issues that board want to discuss from a quality perspective and that transgression, if you like, towards where we want to be in framing this report for future discussions. And Jane touched on it earlier. So Keith and Sue coming, and then maybe we can pick up a bit more of the detail where people want to.
Just before I go to Keith or Sue, can I check, Jane, is there anything you want to add by way of colour or context before we open up more widely?
I think my report earlier covered most of it, but what I would like to say though is that when QAC has been considering the IPR, just linking back to the earlier item, actually if you look at the quality metrics, there is some great progress being made. And whilst we are doing a little bit of navel gazing and thinking about effectiveness of the committee and our processes, I think it's only right that we recognise the great progress that's been made in some of the quality metrics. So I wouldn't like you to go away thinking that we are trying to fix something. Actually, what we're trying to do is really improve something. And I also like to say that I think that the governance team who support the quality assurance processes really need to be applauded, because it's the only area that has continued almost in its entirety throughout the whole COVID period. And the breadth and depth of information that's been received has continued to give us significant assurance. As I said earlier, the only exception being we continue to want to work to improve and move quicker and faster around the clinical effectiveness pillar.
Thanks, Jane. Sue.
Thank you. Yeah, thank you for the report. I just wanted to focus particularly on the patient experience stuff. And in the report it says that we implemented SMS for patient feedback in July, and we're exploring that for maternity and GP. I would just urge that we crack on because it's such an, in theory, easy and quick way of doing that. And also talking about NHSE exploring the potential for restarting and holding a series of workshops and so on. And again, given that we've got such great capability and we've demonstrated it in our own teams about coming up with ideas and getting on and implementing them, I would say let's not wait for a series of workshops. Let's just crack on and do more of our own brilliant ideas and getting patient feedback where we can. But I would really like us to move the SMS stuff forward, which looks like we are doing, but just to accelerate that where we can. That was just a comment on that. I know we've talked about it at lots of boards before. Thank you.
Just before we go to Keith, if I could add to that, the value is not only in collecting it by SMS as a good channel, but it's about the immediacy we would then have the potential for relaying that as real-time feedback. Because I'm conscious that a lot of our approach to date has been behind the scenes and feeding it to board and trickling it down the organisation. And the purpose of feedback is to get it as quickly as possible to the person closest to that patient that can do something about it immediately. So if you think about the stagecoach example where you're sitting on the bus and you send a text to say, my bus driver is driving in a wobbly line and I don't like it. Stagecoach contact the bus driver pulls over and he walks down to seat 3B and goes, why are you finding this a wobbly journey, ma'am? What can we do about it? Sit in a cushion, or whatever the solution might be. But that sense of us acting on feedback in a way that is much more agile and patient-centric with all the modernity of normal customer practices, rather than this slightly more antediluvian approach to insight or, reflection on general improvement in the fullness of time, would, I think, mark us out as serious about patients and innovative in our approach. So you can think of here all those questions. Keith.
Hello, Helen. I think you've partially taken some of the wind out of my sails, but I'll forgive you for that. I was going to be a little bit more challenging in saying I don't think SMS is anywhere near a big enough step. I think that's a backward step, if I'm honest. It's not paper. It is SMS rather than paper. I think my challenge was more, I think we should be thinking well beyond SMS, actually. There are examples now in NHS trusts throughout England where patients in a ward can provide feedback which arrives 15 seconds later at the ward desk for the sister to look at or the matron to look at and take that feedback as directly as possible. And I think we're very limiting ourselves by looking at SMS as a medium. I think we should be moving to something substantively more slick and organised than that. And there are lots of examples of that already in the NHS. I'm not talking about bringing, West Coast US Facebook technology in. This stuff already exists, but it's live, it's much more interactive, and it's easily collected, and there isn't a cost, which there is for SMS. So the cost of usage is zero. So I wanted to just be a bit more challenging. And Sue, I didn't mean to make you feel like a dinosaur. I do apologise. That was me, Helen, sorry.
Yeah, good looking dinosaur, Sue, don't worry about it. No hunches on your back. I think it's a really good comment, Keith, and we've been talking about this for a very long time. And it's, you know, we need to decide now whether or not we're going to keep talking about it or we're going to get serious about it. Ironically, if we'd done something about it when we first talked about it, we would be an innovator and shaper in this area. But I would settle for being a willing follower because it would make a huge difference to patient experience. I think on that note, and it seems like a suitable sort of segue, I'll just check if there's no more hands up, but we might go to...
Lee's got his hand up.
Oh, Lee has. Yeah, sorry, Lee, missed you there. All floor is yours.
I was going to be even more slightly challenging, and my exec director colleagues have the permission to come and hit me after I've made this point. I think the report does read still slightly in the space of what does safety, quality and experience look like when folk have got here? I wondered whether or not other trusts were able, working with commissioning colleagues, to kind of face into the challenge we've probably got now, which is during the pandemic, to what extent have we had patients not getting here, and whether or not the CCG is commissioning some work or whether or not we can participate in some work which looks at, have we now missed a range of cancer diagnosis and chronic disease stuff because people have been... I was just looking at the report. I would have thought the biggest quality risk we've got at the moment is people not arriving. And I just wondered to what extent we could sort of face into that issue, perhaps.
That's a very good challenge. What are other colleagues' views about that? Sue?
Sue's just waving, I think, so I was putting my hand
Oh, you
up.
were putting your hand up. Well, you go ahead.
Not waving back to Sue. Just to say apologies, Sarah's got a signal issue, so that's why her camera's not on and she's dipping in and out of the conversation, but certainly wanting to take her. She can see and hear, but it won't let her put her hand up or comment. So I don't know whether Sarah just wants to come back in on some of that discussion.
Can you hear me?
Yes, we can, Sarah.
Well, it won't let me send messages or put my hand up. I apologise. Yes, really happy to take up that challenge, Keith and Lee. And equally, I think we're well positioned with our Royal Primary Care colleagues to take up some of that system approach to patients, as you described, Lee, and pick up how we join up the information from Royal Primary Care through to here and other primary care facilities. We have some system space working with through our services, so we absolutely have an opportunity to join that feedback together, because you're right, it's only once patients get here. So yes, really happy to take that challenge up.
Thank you for raising that, Lee, and for your response, Sarah. I think you do have your hand up this time, Sue.
I do, sorry. I did before, but it just wasn't on that question. It was just a point further down in the report, which was about the GIRFT update following the stroke meeting. And it looks like, you know, it's talking about the action points been identified, have been reviewed and some things. I would be very keen at a future report or board that we kind of do the so what and what next on the back of those actions that came out of the GIRFT review. Because it does look like it's good stuff, but I would like to understand more about exactly what the outcomes of those are from the stroke unit perspective.
We've had informal feedback to date, so we're awaiting the report. So we thought when we get the report, we should have a discussion at public board, but we will be getting headlines later from Hal at our meeting in private about that informal feedback. So thank you for raising that. Very good, and some comments there about making the links with JUCT, so thank you for that offer, Jane, and thanks also Jeremy for the comment about making sure that RPC is duly prominent in the quality report. So we'll leave that one with you too, Sarah. Conscious also that I've seen Krishna dialed into the call, so hopefully there's a few items, Krishna, emerging for your to-do list in that regard. So if I can move us on, please, to item 8, which is the patient and staff experience report. You'll recall that we're bringing both of these together, but Zoe's going to lead the charge.
Thank you, Helen. And a couple of things I'd like to highlight in the report before opening out for wider discussion. Firstly, we're delighted and proud to have been shortlisted as finalists for the HPMA Award for Excellence in Employee Engagement. We've got the virtual ceremony tomorrow, so please keep fingers crossed for that. And secondly, the annual staff survey for this year has launched this week, in the last week, and the paper describes how we're needing to do things a little bit differently this time around. So we'll obviously keep Board and People Committee updated as we go through the staff survey period. The majority of the paper talks about our exec sponsor activities, so we can open that up for discussion as usual if that would be helpful. As part of the exec sponsor part of it, I'd be interested in, thank you Sue, in feedback from Board around whether it would be helpful to have any sort of metrics or data alongside the kind of the narrative around the exec sponsor role, whether that's something that Sarah and Krishna and myself want to think about in future for some reports or future reports. So I'd be, when we open up for conversation, interested in any feedback about that, please. So I don't know, Helen, did you want to have a bit of a conversation about exec sponsors, or I'll take a step from you?
And we might have a little tour around the table in time-honoured fashion, if we may. Volunteers worth 1,000 pressed men. Who'd like to go first?
I don't mind carrying on while I'm on, and then I'll mute for a while.
I think we should pass the baton to somebody. That could be the the approach.
Oh, like throwing a ball in a game. See who I can see on the screen. So my two teams are Eastwood Stroke Unit and Murphy Ward. We've talked a little bit about stroke services that's been touched on earlier today. I think in conversations with both teams over the last couple of months, clearly we've been talking about how people are feeling. So I've been very interested in how people are feeling at the moment, whether people have been able to take their leave, take some time off really over the summer months or before or after. And I've been pleased to hear that people have been able to do that as we sort of get ready to sort of, I guess, the second wave come in. With Murphy also, they've had quite a lot of change. So the wards actually moved, physically moved, so they were quite happy settling into their new environment. They were quite liked where they are at the moment. And also when I visited them, they'd only just had their care accreditation visit, which board members will be familiar with that process, and they'd had their informal feedback around that. And there's been some really positive feedback around sort of patient experience and patient care, and they felt like the things to do better feedback were things that they would be able to do. So they were saying it was more around sort of documentation and making sure that what's done is properly and fully documented. So they felt that it was within their gift to be able to make quick progress on that. So the mood felt relatively good, and we talked a bit about sort of team development and some ideas for things that they'd started to do, like dog walking was an example, socially distanced dog walking, just to sort of build on that team spirit that I think's developed in lots of places. We've all felt that during the pandemic, and when I've talked to people, it's about how can we keep that coming together as a team, how can we foster and keep that as we move forward. So I'm going to hand over to Lee, because you're the first person I can see.
Thank you. In terms of Durrant Ward, I mean, they've had a really interesting time in terms of switching back on their acute frailty service, and they've self-selected to join the acute frailty network, which needs an exec sponsor, which gives me a little bit more. I sometimes struggle with this role in terms of visible leadership with a purpose, but if I'm the exec sponsor for the acute frailty network and getting a little bit of sort of outside in and helping with that, I think that's quite positive. A, that they've selected to do that work, and B, that they thought it might be a good idea if I participated in that acute frailty network programme, which I think will give us a bit of insight into what's happening elsewhere for our acute frail patients and how you better join together sometimes the gaps that can occur between general practice provision, social care provision, and what happens in secondary care. So I'm off to see them again, I think, in a fortnight, and I'm specifically going to their acute frailty MDT to just discuss some of the reality of sourcing the right sorts of placements for our patients in terms of step down and wider care. So that's Durham Board. So that's quite interesting and exciting, and I'm enjoying that. Then in terms of elsewhere, in terms of RPC 3, they were in a much happier place when I met them about a month ago now than they were in the first visit. They've got a bit more corporate support. They've been a bit more focus from the RPC 3 management team about assimilating them into the wider fold. So they were in a significantly perkier place as a management team in terms of RPC 3. So that was positive, and they want me to go back and see them again next when we've landed further elements of the RPC strategy about what does that mean for their practice. So I think both these engagements are going well, and it's very useful not just to speak to the management teams, but some of the touring rounds, speaking to the frontline staff. So I think more positive reports. I think there's a lot to do in the frailty agenda, as we are well aware, about how we join some of these services together.
Pass the baton, Lee.
Do you want me to come in at this point, Helen?
Not.
So it's Hal here. So I've focused in the last month on visiting some of the outpatient areas, which is one of my things. So I've visited suites 1, 2, 3, 4, and ophthalmology. I'm not sure what number ophthalmology is, but the common. So there were some common themes. There were themes regarding concern for the staff there about social distancing, and some practical things about how, for example, they're able to have breaks and to get their dinner and so on in a socially distanced way. And I've fed that into the various conversations we've had about wigwams out in the premises and so on. And so I'm not sure we've come to complete conclusions about all of that, but I have been feeding back to those outpatient areas that we are listening to their concerns about how we are trying to manage that as best we can in difficult circumstances. So I suppose that was one theme as a sort of general thing across outpatients, concern about how they're able to get their breaks, work safely in their environment in areas where sometimes things are really quite compact, shall we say. And then the other theme that came across in a couple of areas was around the sort of operational issues of restore and recovery and how we could help with that. So, for example, in Suite 1, they had a concern about space for receptionists within the department, and with the footfall being different and the kind of flows within the department being different, they were really struggling with just having a single receptionist. And so I was able to support some work with the surgical division, which runs Suite 1, about changing the setup of the receptionists and support having more receptionists there in order to be able to direct safely patients when they're coming in for face-to-face appointments to the right place, and make sure that was done in as safe a way as possible. Equally, for example, there was another operational issue in Suite 2 to do with ENT, to do with airflow in ENT, which was really impacting on the throughput of patients that we were able to do, because a lot of ENT procedures are aerosol generating procedures. So again, that I sort of picked that up and have been working with estates to try to help some of those operational issues, which hopefully from the point of view of the staff working there allows them to, or makes them aware that we are listening to when they raise concerns, and we are trying to do something about it whenever we can. So if I pause there.
So welcome back. I hope you're suitably refreshed. And we're just about to go to item 10, which is our EDI annual report. Zoe, please.
Thank you, Helen. So our annual report also includes our RES and WDES outcomes for this year. There's a lot of information in the report. There's a lot to say around all the strands of diversity and inclusion. My specific, so I won't draw anything out in particular because I think there's too much to sort of draw out highlights in particular. My ask of board and the conversation I'd like us to have is specifically around the objectives we've sort of highlighted for next year, which are in Appendix 1. Also in Appendix 1 are the measures, the kind of success measures, the quantifiable ones we set as a board earlier in the year. The report does describe that it's early on still to be able to measure some of those, and because of things that have been paused nationally, we've not been able to kind of measure all of those. So I will be bringing an interim report back to board in around March next year, prior to the next annual report. So yeah, so it's are we happy with those objectives? Is they the right kind of things? And also on a practical level to approve our RES submission, please, which is in Appendix 2, the narrative around the RES.
Thank you. That's very helpful steer, Zoe. That's appreciated. Who'd like to come in on this? Jeremy, would you like to come in first?
Okay, thank you. Thank you, Zoe. I think it's terrific to read about all the good work going on here. I mean, notwithstanding the fact that we'd like to have shorter papers, but if we're going to have a long paper, let's read about good work. So I'm pleased with that. The one thing I would add, or one question I'd ask, is about the Be Yourself group, and I've made a little note to myself on my scribble here. It says, can we quantify more the Be Yourself group activity? And I wonder whether it's possible to have some numbers around the kind of work that's doing. As far as the objectives go, we do need to approve these at the board today, and I'm personally happy with them as they've been laid out, but I'd be interested in other people's comments on that.
Thank you very much, Jeremy. Other colleagues? Are we happy with Appendix 1? Lots of nods. Are we happy with the RES submission? Lots of nods. Just before we conclude, and of course in anticipation of the planned conversation at People Committee, there's a couple of comments I'd like to make, but I'm just going to go to Atul first.
Thanks, Helen. Just a small thing. I mean, insofar as this is one of a couple of annual reports, and so they flesh out things that we won't put into our main trust's annual report. But just as you give an introduction, Helen, to the annual report, would it be worth Jeremy also, or the relevant NED or committee chair, putting their imprimatur on this by way of an introduction, and that can then talk about what we as NEDs feel has been achieved. Because I know the function of a lot of these kinds of annual reports is regulatory. We've got to report certain things, but it can draw out what we as NEDs and as a board feel about the issue and where we think we're going. And a small second point, which is, and I'll make that again perhaps later on about the infection annual report, is plain Englishing all of this, because as an annual report, the audience is the wider public rather than just the board. And so I think anything we can do to make the language much easier to absorb by our members, our volunteers, the general public, governors and so on, I think that would be much appreciated. This is not as in that category. I think that the following report is probably needs a bit more of that treatment.
That's, I think, a very helpful suggestion, Atul, and would help bring our commitment to this agenda to life, as well as the substance of our actions. So I think that's to be welcomed. The additional contribution I was going to make was to share experience with you from elsewhere. So both as an oversight regulator for the legal services sector and as a frontline regulator for health and social care profession. we're looking at this very much not only about diversity for the protected characteristics on entry to various aspects of the profession, but also in terms of progression through. And there can be quite an alarming difference in success at those 2 points and at various points in the career ladder. And we've decided in both those places that it's not sufficient to be able to report the data in the absence of being able to describe what we believe the barriers to be, what the mitigations are, and what the assessment of the efficacy of those mitigations are, with a separate and additional reporting requirement around disciplinary activity in respect of all protected characteristics. Now, I appreciate that they're not going to map across seamlessly to a trust workforce, but there's some elements of that thinking that I think are very helpful, particularly the progression elements and particularly the requirement to not only describe mitigations, but to be able to demonstrate a handle on the efficacy of mitigations. So just leave that perhaps with the People Committee for some further thought when you have your next discussion of all of this.
Thank you. Really helpful comments. Thank you, everybody.
Very good. Thank you, Zoe. So that brings us on, if we may now, please, to the next section, Management of Risk and Performance. And we have a number of agenda items here, notably item 11, which is about the phase 3 recovery plan, and of course how that sits alongside our winter plan. Tony.
Thank you, Helen. So I'm just going to focus on highlighting a couple of differences since I've last spoke to the board, and then a little focus on the ask. Just to restate, the national alert status is 4, the NHS response level is 3. You will know from news all over the country that the prevalence rate is rising, highly variable by region, highly variable within region. So much so that our regional NHSLA colleagues have got themselves on a 7-day footing in terms of their governance, which now includes not just COVID, which over the last few months it's covered, but also winter and also Brexit. We submitted our phase 3 plan on the 21st, as was the plan, both as an organisation and as a system. Key difference even with that submission, because our working assumption there was the peak would probably occur in mid-December. You will know with the social distancing issues across the country and across our region, that is expected to occur a lot earlier, possibly in October, mid to late October. And we can already see our numbers rising. On that basis, post-submitting on the 21st, on submitting on the 21st, we were saying that between the different pathways, we weren't going to be compliant in some of our elective challenges. So post-submission of that, there's many conversations going on as to what are we doing to try and improve that position, and even situation reports as to if on certain working assumptions on the scale of COVID, what are you going to do to continue with your elective work? I think I've reported to the board before that we have designed our pathways both to cover COVID, urgent, normal winter planning, and our restore and recover to keep a safe hospital and safe for our patients and safe for our staff. But that is resource hungry in terms of doing that, and that's one of our challenges about scaling up in the way we're being asked to. The 3 points I would have drawn out, one we've already made reference to, because the absolute focus is on the patient. Our clinicians are reviewing all of our patients and its clinical priorities that focus our restore and recover. So I'm pleased with the conversation we had earlier, because I would have been asking you to note that performance won't necessarily improve to scale whilst we're focusing on patients, and we had that conversation earlier. I would want board to be very mindful of the balance, because the reality of the modelling, whether it's December or whether it's October, if urgent care scaled up to a normal winter, and if COVID happened to the scale that it might as a second wave, and we continue to restore and recover, we do not have enough beds to service all three. And depending on which escalation occurs first, then it will trigger a de-escalation, almost certainly of the electives. So that's the balancing act I want board to be very mindful of and supporting us every day as we manage that. And then finally, so one is just to support us with that balancing act. And then the final one, you'll notice from my blogs, they've increased in frequency. So Sarah's been brilliant in supporting me with that. But with that balance and with those different pathways, the adherence to infection control guidelines is key. And even today, we will issue another blog and we'll tease the organisation a little bit in terms of their knowledge. So we'll run a bit of a quiz. But it is getting to be a bit of a fine line now with this is what we would like you to do and how to keep each other safe and your patients safe, and then practicing those disciplines. So if there was a conversation point, Helen and board, it would be your views on how strong a message to put out to our organisation around social distancing, because there's no disciplinary issues or anything like that, and I'm not advocating there should be, but there is issues. So I'd stop at that point, Helen. Patient versus performance, thank you for the guidance earlier. Mindful of the balance between the different pathways, but our teams sticking to the disciplines that keep them safe and their patients safe is really, really important.
Thank you, Tony. Do colleagues want to come in?
If I may, Helen, again, just to feedback the picture across the region, I think really positive. Sarah's highlighted it earlier, and we know from our infection control prevention work that we touch wood not had any of those nosocomial infections, but we are always at risk and always will be as we go through the next few weeks and months. I have a personal view around how we handle that day to day with people, and I think it's the way you do it rather than the what we do. But we are grappling a little bit both nationally, regionally and locally with how firm a message we implement with our staff if they're not abiding by the rules. And that's the request from Tony and myself and others around board's view on that. And would just pause there for others before I say too much more around my own personal stance.
I'm happy to lead the charge on this while colleagues think some more, but this is about colleague safety, and we have an obligation to them as individuals, let alone in the interest of keeping them fit and well, to look after our patients. So it's very important that we do everything that we can to protect them and their families. And that shouldn't be a hard message to sell. So I'm assuming, in the spirit of you saying it's how we do it, that's very important, that we will be persuasive, tenacious, determined, and all of those good things, but absolutely making sure that we don't leave anybody at higher risk of having COVID than they would if they were at home or in any other walk of life. So I will be surprised if colleagues tomorrow, but I see Zoe's hand up, so we might go to you first, Zoe.
Thanks, Helen. So I agree with your sentiment. I just wanted to feed into the conversation some of the feedback we've had from staff partnership colleagues, and I think at forum as well. And this is very much about the how we do it. So I don't think I'm paraphrasing when people have said sometimes they feel people are getting told off. So we had quite an interesting discussion in those forums around that's, the purpose is it's not about telling people off, it's about keeping people safe, etc., as you sort of described it. So I think, like most things, it's the how is more important than the what, really, just to emphasise that point.
Thank you. Jane?
Yeah, same point, really. It is about the how. I absolutely believe it's about the how. And I wanted to applaud is it a crocodile or an alligator? The 2 metre. I've seen it about the trust, and it's just kind of, I thought it's a really, yes, it's light-hearted, but it's a fabulous way of getting over the message about distancing. So our inflatable crocodile is 2 metres and being used very effectively to kind of highlight spacing. And I thought, you know, when we're talking really about trust versus coercion, the same as the national stuff here, aren't we? But I thought that was a great way, and actually, you know, we need to do more of that sort of stuff in our messaging.
Very good, Lee.
Sorry, Helen, I wanted to lower the tone slightly and talk very momentarily about money, for which I can only apologise. So it's a slightly different point. Self-evidently, for the first half of the year, we've had this funding regime which has said almost the NHS can spend what it kind of needs on COVID. We now understand a little bit better what the system allocation is for the second half of the year. And there is going to be quite a crunchy conversation at some point about what we can and can't afford to do. So I keep making the point locally and nationally, if we set the height of the hurdle race on elective and day case surgery at the end of July, it would have been a very prescient thing to do to enable us to do that, to really understand winter and where we'd be at with COVID. And a lot of the cost estimates we've got in the system for the second half of the year relate to quite ambitious plans about further elective and day case work. And the consequence of some of that, along with other factors, is our current estimates show we perhaps don't have all the money that we need to do this phase 3 recovery. So all I wanted to do was herald that is going to be quite a crunchy conversation in the next Finance and Performance Committee in October. The first iteration of that conversation has been held with accountable officers on Friday, because at some point we're going to have to be told the money is more or less important than the ambition around winter COVID and elective surgery restoration, and how we balance those things up. I'm sorry to lower the tone, but at some point we're going to have to be able to describe those trade-offs.
It doesn't lower the tone at all, Lee. It injects a helpful reminder of what's to come. I think I'd add to your comments by saying it is yet to come. And, you know, we've been talking about how to deal with colleagues and compliance. But if we kind of to widen the debate out briefly, and I'm conscious you want to come in, Sue, so I'll come to you in a moment. But on the wider elements of this report, I mean, I think we need to reflect on the fact that our executive colleagues have been enormously diligent in the way in which they have tortured themselves in getting the most accurate estimate possible about what is achievable with current constraints for restoration and recovery. There has been no sense of, you know, that's the answer and we'll fill that in as the answer and then we'll see what the winter brings. There's been real diligence about making sure that we do absolutely the best we can for every patient that either needs us and is on a waiting list or might need us over that period. And I think we have to recognise that, as colleagues have said, we're in a very dynamic period where we're going to have to make decisions with a bit of flexibility and agility. And I suppose this will make colleagues who know me well laugh, and my propensity to be very hawkish around the money. But I do think that planning at the moment needs to go on, not overly burdened by likely financial constraints to come, and needs to focus on patients' clinical priorities and the art of the physically possible in a COVID constrained operating environment. And I think we will get our heads around filthy lucre in due course, along with the rest of the nation. So I hope that isn't giving you as finance director a dose of the wobbles, Lee, but it seems sensible proposition for the moment to me. Sue. You're on mute, Sue.
I think I'm off now, sorry. Yes, thank you. That was helpful, because I was sort of frowning and then Lee came in to talk about that, so that was helpful on the money front. I suppose this is such a difficult subject, isn't it? And I think the paper lays out really clearly where we are. I'm quite amused that the NHS thinks we have a window of opportunity between now and winter, because it feels like winter already is here. But I guess I'd be interested to hear a bit more, really, just about if it's even feasible to answer the question, but how are we going to balance those risks? And I'm thinking purely about the patient bit of it. I appreciate Lee will tell us we need to think about the money. But I'd be interested also to think about what others are doing and the extent to which that as part of the overall system. If it's about space for patients and workforce to look after them and money, we are part of a wider system, aren't we? So, and I went in it talks about in the rest of the plan, the workforce. So I'd just like to kind of explore a bit more around that, you know, and then community capacity and so on. And whether or not we think there's more that we could do to explore some of those actions and mitigations about those specific risks around workforce, I think, and capacity. Because I'm not necessarily sure that we that whilst the report calls out workforce as number one on the list of risks, I'm not sure that the actions and mitigations are necessarily giving us comfort that we will be able to mitigate those risks. It might just be that I'm not pulling it out from the report clearly enough, or maybe it's just that there isn't a magic answer yet, but I would just like to explore a bit more about that. I don't know whether Tony's got any immediate thoughts. Yep. Or Anne looks like she's chomping as well. So can we just leave you to have a think about that one for a moment, Tony? So make a note of that. Yeah. And I'm going to go to Jeremy. Jeremy.
Well, in fact, I was going to raise exactly the same point. The plan identifies those risks on that slide, but I was wondering what we're doing to address those risks. The other comment quickly while I've got the floor is, personally, I found it really difficult to understand the flow diagrams earlier on in the presentation, and I think I would have valued a bit more text around those. But the key point is about the risks.
Thank you. So if we can come back to Tony around all of that, please.
Okay, so it's probably worth mentioning during wave one, where it was a much more simpler equation of an unknown in terms of what is COVID. We set up all the pathways to allow us to have COVID suspect, COVID positive, and then normal stuff, and then a load of activity was stood down. In that way, you're virtually creating, whether it's 2 hospitals or 3 hospitals within our existing hospital. And it was all hands to the pump, and we could put resources where we needed to. But once you create a COVID suspect or a COVID positive or a clean area, there is no, oh, I'll just help you out. You know, so I'll just help you out in whatever you're doing. You can't do that. They can't go across those pathways. So actually our resources have to stay in the pathway they're at. Then the other thing about COVID, when you're in the ITU and in the ward areas, then you need additional resources to support staff, because it's much more intense, to don and doff, and there are additional roles within the theatres to allow certain things to go. So that diluted our ability to open our other theatres. In developing the different pathways, particularly in ITU and our theatre areas, then it is very complex in terms of imagine an ITU and a HDU, both COVID and non-COVID. All of a sudden you've got 4 elements instead of 2 to cover. So that's where your resources get stretched. And then equally, we lose staff to either they're shielding themselves, because our vacancies aren't an issue as much. We've actually done really well with the recruitment. Shielding, isolation, either because you've got symptoms or a family member's got symptoms, those type of issues. So all of these challenge the availability of our resources. And then overlay that with social distancing and infection control procedures, what you can and can't do with aerosol generated procedures, the limitations on that, all the clinical prioritisation, all of society who are nervous about coming into a hospital. These are all the different issues that make running effectively 4 pathways as opposed to 2 very, very challenging. And as you go into different specialties, they'll have their own nuance on that. I don't know if Hal or Zoe or even Sarah want to come in on other aspects of that.